The physical exam is incredibly important in managing myositis patients. Sometimes, as you're saying, it takes a few weeks for some of our autoantibodies to come back. Over the course of the last few years in my practice, I think it's often become hey, I'm going to try and preemptively decide what subtype this is and make my best educated guess. And it's kind of like I nailed it based on my physical exam. That still counts.
That's Dr. Fergus To. He is a clinical assistant professor at UBC and serves as a consultant rheumatologist at Vancouver General Hospital and St. Paul's Hospital. He started the Vancouver Coastal Health Myositis Clinic, for which he was awarded the BC Society of Rheumatology Award for Innovation. His research interests are in quality improvement and novel therapies for myositis. We are thrilled to have him on as our guest on this episode of Around the Rheum to talk about myositis. Welcome to everyone. I'm Daniel Ennis, and a warm welcome back to my fabulous co-host, Dr. Janet Pope. Janet, how are you?
I'm great, and how are you, Daniel?
I'm great. It's really nice to see you. It's been too long.
That's right. We got to keep these podcasts coming.
I know. Okay, well, I'm really looking forward to this conversation. So without further ado, we'll add our guest to the discussion. Fergus, welcome to the show. How are you?
I'm well. Thank you so much for having me. It's very exciting. I listen to your podcast a lot.
Thanks. Well, we're very excited to have you. I, in particular, am very excited to have you because I think among my various deficits as a rheumatologist, I would say myositis is an area of weakness. And I think it's kind of exploded in complexity since we were in training. And so I'm really looking forward to kind of getting some of that synthesis from an expert like yourself. So before we start grilling you on the topic, I'm wondering if you can tell us a bit about your experience training in myositis. How was that?
Good. It was very enlightening experience. I think, as you were saying, we went through our rheumatology training together, and at that point, that's when a lot of this was exploding. I was looking back to see when some of our antibodies that we use now were discovered, and they were just being commercially available when we were in our training. So dates us a little bit. So it was very exciting during that time, and I think it's continued to explode. So I was able to go away in the UK, learn from some of the experts around there. And it's been really nice. We were recently at the GCOM, which is the global conference on myositis, and we're just watching the phases, how it's progressed over the last few years. The most recent one, they had like several hundred people attend. The years prior, it was much, much smaller, and I think it just exploded. I think now the trainees are approaching us, and they're actually able to go to real myositis fellowships there. As you're saying, it's really exploding as we go.
I'm really excited for this conversation. So, as we said, there's been kind of major changes in antibodies, but I also suspect there's been major changes in how we categorize and approach inflammatory myositis since our training now many years ago. Could you set the table a little bit by outlining the general categories of inflammatory myositis that rheumatologists need to be aware of?
Absolutely. So we were taught, and I think they're still teaching this in medical schools for whatever reason, the old school classification of PM or DM, so polymyositis or dermatomyositis, which is a very simplistic approach. So if you have a rash, it's dermatomyositis. If you don't have a rash, they just categorize it as polymyositis. But we know now that within the subtypes, because of all the different autoantibodies, we need to think about our classic dermatomyositis, but also amyopathic DM, the one we often think about as MDA5. We fear that one a lot. Antisynthetase syndrome is another one. The necrotizing myopathies, cancer-associated. And then we also think about overlap. Within overlap, we're starting to see there may be even subgroups with that. So our colleagues out of Quebec, for example, they're the world leaders in describing scleromyositis. So that's, I think, in a few years down the road, we may actually see that itself is its own distinct entity.
That's very helpful, just for kind of a framework onto which to discuss the rest of these complicated diseases. Janet, what are your thoughts?
Right. So first of all, I did learn it the old-fashioned way, but one thing that I would ask about is, inclusion body myositis, does that sort of not even get into the classification? We just say, oh, it's a different problem and kind of not very treatable.
Great question. So I think it depends on who you ask. But so usually when we think about the inflammatory myopathies, they actually still will. I should have included IBM in there as well. I usually think of it as its own distinct subtype because it is not one that is very amenable to immunosuppression. The 2017 guidelines, they still included the ACR Euler ones. They still included that. I think we should still think of it as its own distinct entity. They are coming up with actually new classification criteria. These were just recently presented. And there are certain subtypes that may possibly be a little bit more amenable to immunosuppression. Again, I don't think there's robust evidence, but I would still say, yes, we should include it. Sorry, I should have said that earlier.
No, that's very helpful. Fergus, can you comment on some of the important clinical features that help you differentiate the different subtypes before you get the antibody panel back? Because that can take some time and you'll probably need to make treatment decisions before that point.
Yeah, absolutely. So the physical exam is incredibly important in managing myositis patients. Sometimes, as you're saying, it takes a few weeks for some of our autoantibodies to come back. And over the course of the last few years of my practice, I think it's often become hey, I'm going to try and preemptively decide what subtype this is and make my best educated guess. And it's kind of like I nailed it based on my physical exam. That still counts. So
it's a cool party trick.
So absolutely. Yeah. So I rely a lot on the rash type. So for example, if I'm looking at dermatomyositis, we'll know, are we looking at mechanic's hands? Are we looking at just classic Gaucherans, right? Then you can start subtyping. Is this just DM? If you're seeing little clues, though, that are more specific for certain myositis subtypes, so palmar papules, for example, you don't usually see that in too many other subtypes aside from MDA5. So that's one clue I'll look for. Or if I'm looking for cancer myositis, we know that there's certain features. And again, it's not entirely specific, but these are clues that would make me think, hey, this might be an anti-TIF1, for example. So if I see a lot of periorbital swelling, for example, I'm thinking this might be a malignancy up front. Or there's something else called an ovoid palatal patch where you're looking inside in the mouth for a little bit of redness here, just on the hard palate. That's another little clue to myself. Also, arthritis is another big one. If you're seeing frank arthritis and not a lot of weakness, you're starting to think, okay, is this actually myositis that's causing any sort of functional impairment? Or is it the arthritis with a DM rash, which would support an amyopathic dermatomyositis, for example? If you see a lot of joint aches, now you're thinking, all right, arthritis, this could be seen in antisynthetase. However, also MDA5 can present with a very frank arthritis as well. And if I'm not seeing a rash whatsoever, then I'm looking to see, okay, what is the pattern of weakness? So Janet mentioned earlier about IBM. So yes, we still very much rely on, is it a distal, is it a proximal muscle weakness that we're seeing? And then of course, if we're seeing frank weakness that's very proximal and you're worried about stand myopathy, then you start thinking, okay, is there anything on my clue that makes me think this is anything but stand? So could this be, for example, pure rhabdo? So I think a common thing we'll see in the emergency room is a high CK, very, very high. Patient's been on a statin for a while, and they're trying to discern, is this rhabdomyolysis or is this statin-induced necrotizing myositis? So then we rely on the physical exam. We'll look at the level of the CK as well. So if a CK level is super duper high, you're not thinking this is going to be myositis, you're thinking more rhabdomyolysis, for example. So physical exam, level of CK, that's what I'm relying on primarily until I get the antibody back.
Can I ask a question, two questions, one about skin and one about pain? So I always sort of learned back in the day that if a patient has skin lesions that are ulcerating, think cancer, but obviously there are chronic patients that are ulcerating around their calcinosis, but as the new feature. So that's one question, if that's really the hand is sort of still true or not. And then the other question is, when someone has pain with an inflammatory myositis, where does that point you?
Great question. So ulcerative lesions, I was also taught in the very beginning, if you see ulcers, think about cancer. But we know that's not necessarily true anymore, because now when we see ulcers, we think, could this be NDA5 dermatomyositis? So those are both on my differential. I think if it's ulcerative, more and more, because we're able to get the myositis panels back, I'm seeing more NDA5 more than anything else. If I see ulcers, I will still look for a cancer until my antibodies are back. And then the second question was about, sorry, what was the second question again?
About pain. So again, we used to not think of inflammatory myositis having muscle pain per se, or pain not being a high feature, and that hasn't held out. But if you see someone with proximal weakness, you think that it's an inflammatory myositis, and they have pain, does that change you? Like quite a lot of pain in their muscles proximally.
I like how you highlighted saying, we need to stop thinking that myositis is not associated with pain. So a lot of patients will say, I'm in pain, and then you do the work and you're like, this truly is myositis, where traditionally we have been taught this is not true, look for something else. So yes, we can absolutely see pain in patients with myositis. We need to start believing our patients when they're telling us that. It doesn't help subtype, though. I don't think it'll help me subtype one versus another, at least not in any specific data that I've seen.
Okay, because I have wondered about the post-statin group that really get chronic myositis, and that some of them seem to be more myalgic than maybe traditional anti-synthetase patient.
I can see in statin myopathy, you do see that as well. I don't know the data well enough to know if statin specifically causes more muscle aches, but yeah, I agree. Anecdotally, that's a pattern I've seen. Anti-synthetase, do I see pain? I see pain in that sometimes as well, so I don't think we can use that as a clear delineating feature.
So those are some really helpful tools, and I do actually want to return to mimics a little bit later on in our discussion. I think maybe this is a good spot to discuss some of the serology. So as we kind of alluded to, there's been a real explosion in the diversity of serology subtypes that you can get or find with inflammatory myositis. And I'm wondering if you can, draw some Venn diagrams for us a little bit, help us to understand, like, how should we be, what boxes do we put these into in our heads? Which antibodies should we really care about, or what's an approach to these antibodies?
So the first way I would categorize it would be thinking, are these myositis-specific autoantibodies, meaning they're only found in myositis patients, or can these be found in other connective tissue diseases as well? And we call those myositis-associated autoantibodies. So MSAs or MAAs is what you'll read in the literature. MSAs really should only be found in myositis patients, and they should be mutually exclusive, meaning if you have an MT-Me2, you should not have an MDA5 that's concurrently positive. There are anti-associated or myositis-associated autoantibodies that can be seen in other connective tissue diseases. The most common one we'll come across is Rho, for example, Rho52. You'll see that in all sorts of different connective tissue diseases, but you can see that in myositis. And that one we can overlap with a Me2, for example. And then what I'll start thinking about is the antibody and which which subtype of myositis it's affiliated with. So at the beginning, you asked me, how do I think about the different types of myositis? So anti-synthetase, for example, is the easiest example I can pull up, because we know that there's the Jo1, and then within that, there's an entire, alphabet soup of other antibodies as well. So the ones we're most likely going to come across are PL7, PL12. Those are usually the ones that you'll see in addition to Jo1. So anti-synthetase is one that I'll think about. And then the cancer-associated ones are another easy one to think about. You've got your TIF1 antibodies. And then the literature also says we should think about NXP2 as well. That one's a little bit debatable, but I think we have reasonable data to still put that in the cancer-associated group. Necrotizing myopathy is another good one to think about. So we think about the easy one to come across is statins, HMG-CR, and then SRP usually falls into necrotizing myositis. What else do we have? Amyopathic. So amyopathic, we're usually thinking MDA5. You can sometimes put your SCA1 into there as well. And then Me2 is usually just classic dermatomyositis. So you can think of it in two ways. The easiest one is the MSA versus MAA, and then tying it up to the specific subtype.
That's super helpful. Thanks for doing that just off the top of your head there. Okay, I think now that we have kind of the broad scaffolding, I'm curious to kind of nail down, how do we actually make a diagnosis? When is enough investigation enough? Because we actually have a lot of tools for assessing muscle. We have our physical exam, as you mentioned. We have the serologies, but we also have biopsy, MRI, EMG, capillaroscopy. And so I'm curious if you can, be more specific in how do we actually decide who definitively has the diagnosis and who doesn't?
I rely on a combination of all of those. I was anticipating this question. I was thinking, well, when do I use EMG? When do I use an MRI? So I think the important thing is knowing the phenotypes, the specific subtypes, is very important. So you can see, do we have enough clues to put the puzzle pieces together to form the general picture? But I don't think there's going to be one specific test, except perhaps, I would say if there's going to be one specific test, it'd be our antibodies. Those would be the most useful one. So if you have a phenotype, for example, like I'll use MDA5 again. So if you have an MDA5 autoantibody and you have ILD, you have dermatomyositis rash, that's pretty straightforward. You don't need a biopsy for that. You know this is going to be an MDA5 dermatomyositis. Rashes are very important. Gottrin's, for example, is fairly darn specific for dermatomyositis. It's if you see a Gottrin's papule and the rest of the phenotype fits, you do not need any sort of other muscle biopsy. I'd spare the patient a muscle biopsy. The other modalities, so CK, we need to be careful. CK can go up in myositis, but CK can also be normal in myositis as well. It's helpful when it's high, but when it's low, you can see that in our amyopathic dermatomyositis, for example. That's when, again, you're relying on the myositis antibody as well as the physical exam. And then, sorry, I feel like I'm not giving you a clear answer. I think this just highlights how many little nuanced pieces there are.
No, I think that's okay.
Yeah? Okay,
yeah.
Perfect. And then the tricky thing sometimes is interpreting your MRI and your EMG reports. So when do you use what? So neither is going to be perfect for your diagnosis. So MRI is great, right? You can scan a large body of, or a lot of muscle. You can see what's involved and you can see where you can target for a biopsy. But an MRI will pick up a lot of other stuff as well. So it picks up artifact. And what's often interpreted as myositis in the impression simply is just muscle edema. It's not specific. So if somebody had rhabdomyolysis, it could look very similar. And the radiologist may simply say myositis in the final report if you're not giving them the correct clinical context. So the MRI has to fit the rest of the clinical picture. And then the same thing with EMG. EMG is non-specific. You're going to see all the patterns. I'm not a neurologist, so I don't know all the different patterns, but you're going to see your low amplitude. You're going to see your positive sharp waves and such. An EMG, again, does not make the diagnosis. It tells you there's a myopathy. It does not necessarily tell you there's a myositis. And EMGs aren't perfect either, so the sensitivity is not 100%. So just because you don't see it on there, if you're suspecting myositis, it may be a false negative.
Are you seeking a community dedicated to advancing rheumatology care, education, and research? Welcome to the Canadian Rheumatology Association. At the CRA, we're more than just an association. We're a community of passionate professionals united by a common mission to promote the pursuit of excellence in arthritis and rheumatic disease care, education, and research. With us, you're not just a member, you're part of a dynamic community dedicated to supporting you in every step of your journey. From career advancement to patient care, join the CRA today and experience the benefits. Enjoy organized networking, invaluable advocacy initiatives, curated training and education, grant opportunities, resources for clinicians, students, researchers, allied health professionals, and so much more. Together, we'll shape the future of rheumatology in Canada and beyond. Join our community by visiting rheum.ca and become a member today.
I was just going to ask, kind of as a clinical pearl, the trainees and those that aren't experts in myositis, they don't think about it every day. Are there some words on EMG that are really helpful? As if, for instance, polyphasic waves, spontaneous fibrillation, the amplitude's abnormal. I realize that they can overlap with all sorts of myopathies, but are there words that maybe those of us who aren't experts should think about, that we should look for these words if we're really wondering about myositis?
Yeah. Fibrillations, positive sharp waves, and then low amplitude is often another one that I'll look for. One clinical pearl I'd say is when you read the report of the EMG, don't just read the final line, but actually look at what muscles they tested. So oftentimes you'll realize, oh, that's not even the muscle I was looking for. So it's of course it's going to be negative, right? And I think different neurologists, they must have a standardized protocol. I don't know if it's standardized, but they will test certain muscles, but sometimes they will miss the one that I'm really concerned about, or they will not done the one that actually lit up on an MRI. So making sure that they're testing the one that's lit up on an MRI, if it's clinically relevant, is very important.
I suppose that would almost be analogous to biopsying the wrong muscle, right? That's why that MRI can be helpful.
Exactly.
That's really helpful, actually. So, like many of our tools, none of them are perfect. They all require kind of expert interpretation, and most importantly, and it feels like we always come back to this, the clinical context really does matter in interpreting these tests. I am curious, does the EMG affect your MRI? Does the EMG affect your biopsy?
Do you mean like where to target it? Or is it going to affect the biopsy result?
Yeah, does it give you abnormalities on a biopsy on an MRI?
Yeah, you can see artifact on it following an EMG. So I remember traditional teaching was get the EMG and then biopsy the contralateral side.
Okay, right, because you've messed up. Yeah. Okay, that's really helpful. So those are kind of some of our tools for diagnosis, kind of clinical and expert opinion being most important. And so maybe that will help us then understand how you sort out some of the mimics. And maybe we can start with rhabdo. That's kind of a nice mimic, because I feel like we, with some frequency see that in the emergency department. Can you kind of hone in on that a little bit? How do you separate out someone with rip-roaring, let's say, a necrotizing myositis from their statin versus rhabdo from their statin, or another cause of rhabdo? How do you clinically do that? That seems quite challenging to me.
Let's break it down to what I would do in front of me. So the history, first of all, you want to know when they started their statin. So if the statin was started very recently and you had a very clear temporal relationship, that actually might suggest it's more of a toxic effect. It's not a clear-cut rule, but if, let's say you started it last week and, all of this happened now, you're in the merge feeling unwell, that suggests it's more likely going to be a toxic effect. And, that toxic myopathy is also a spectrum. So you could just have a direct toxic myopathy where it's a blip in your CK and you're feeling unwell, to the point where you have frank rhabdomyolysis. Again, not a clear rule, but that's the first thing that I would ask about, versus if they've had a statin for years and years, and this has been the slow, grumbling decompensation, then that suggests it's more likely a necrotizing myositis. And then the physical examination, this one's tricky. So what I'm looking for in a physical exam here is a clear proximal muscle weakness. That's going to help me think, okay, this is more myositis. Whereas patients with rhabdo, you're going to get more diffuse muscle aches. You can get weakness proximally and distally. However, I think in the physical exam in the emergency room, it's going to be sometimes very, very difficult to differentiate that. But try your best to look for that gradient in the proximal versus distal muscles. MRI may be useful. So I recently saw a case where it's exactly this: is a statin myositis or is this rhabdomyolysis? So the MRI report actually did say myositis, and the treating team thought, okay, let's go ahead and treat this. But of course, in the end, it turns out this was actually a case of rhabdomyolysis. So when you go back and retrospectively look, okay, what were the clues that could have told us earlier? So the CK rise did come on pretty quickly after starting the statin, as I mentioned, but also the CK value, right? It's really, really high. When you're looking at 50,000, that's more suggestive of rhabdo. Usually the necrotizing myopathies, you're going to see a level lower than that. And then other clues, if you see any sort of improvement with intravenous fluids, I would just keep pushing the fluids. Make sure they've had a good challenge. If you see a little drop, just be patient. Try a few more days where you're really pushing hard. I know sometimes in the clinical setting it's difficult, but if they're improving even a little bit before you commit them to a long course of steroids or IVIG, let's just push that fluid. Make sure they've really had a good chance to lower it and clear their kidneys. And kidneys are another one. So if you see an AKI, that's much more likely indicative of rhabdomyolysis. So patients with myositis don't classically get that same type of kidney injury. So if you see an AKI and it gets better with fluids, again, rhabdomyolysis is what you're thinking.
I just find that so interesting because you can still have, when we were doing our internal medicine together, CKs in, above 5,000 are still concerning for, renal injury. And you can get that with an inflammatory myositis, certainly not as frequent as with rhabdo. But I can't say that I have really seen that many AKIs from our inflammatory myositis patients, despite having those high CKs. And I always found that quite mysterious. So I never looked into it, but that's interesting that you've mentioned that. Okay, so AKI, that is more suspicious for rhabdo.
Absolutely.
And a question about that, Fergus, as well, is it's often the medicine team and, frankly, the rheumatology team where everyone wants to trigger, let's give Solumedrol or whatever. So I always say, we have to look because a CK that's rising quickly can still only go down so far per day. Do you have any rules, like you can go down 1,000 a day or several hundred, or is there any kind of rule?
I don't think there'd be a rule for that. I think if it's going down, just keep pushing the fluids for the time being.
Mm-hmm. Give it time.
Give it time. Be patient, especially if the patient's clinically stable in front of you. There's no reason to pull the trigger on that. And then one other little tidbit or a little trick is I'll look in the urinalysis as well, right? Look to see if there's any hemoglobin in there, which can represent myoglobin from rhabdo as well.
So if they're 3+ blood and no red cells on,
exactly.
You would say, I think it's myoglobinuria.
Possibly,
and,
exactly.
And that again would far suggest rhabdo over inflammatory myositis.
Exactly.
That's also interesting, right? Like, why don't you get the myoglobin from muscle breakdown from an inflammatory myositis? Is it just kind of the quantity of pigment, like the quantity of myoglobin being released, or is it a different process that's causing that?
That's a great question. I don't think we know the exact. I don't think it's the same degree of damage that you see in rhabdo, because rhabdo is, frankly, things are just bursting all over in your muscles, whereas the inflammatory process is inflammatory.
Right. That's very interesting. Maybe we certainly want to spend some time talking about treatment and cancer screening. Can you kind of run through maybe just a couple of other important mimics that you think we should be aware of as we see these patients? Are there other kind of groups of diseases that should come to mind we don't want to miss?
Yeah, absolutely. So the things I will always test for, I will test for a vitamin D deficiency. I've seen CKs in the thousands from vitamin D. I recently saw a case where I was referred this poor young lady who went to the Emerge, and they thought they were wondering about, and she felt swollen all over. And then I saw her because my allergy colleague didn't think it was an allergy, referred to me because she was in pain all over. And I said, well, let's just run your CK, let's see what'll happen. I almost thought it was fibromyalgia. Her CK was 1,500. I thought, that is weird, but this does not look like myositis. And of course, everyone gets a TSH check like 5 times every month when they're in Emerge, but for some reason her TSH had not been checked, and I looked like a rock star when I said, I think you just have hypothyroidism. And we treated her thyroid, and she got immediately better. That's another one to think about.
Incredible.
Yeah, I've never felt smarter than that.
That's a good catch.
Yep. What else do I think about? I think about drugs as well. So we think about colchicine, right? We use colchicine frequently. Think about your alcohol use disorders, and then neurologic issues as well. So I will rely heavily on my neurology colleagues if we're thinking about metabolic abnormalities or neurologic abnormalities. Crush abnormalities. What else am I thinking? Muscular dystrophies. Those are usually the key ones I will think about. And then if you're thinking, okay, this might be something that's related to a metabolic myopathy, I always just ask, what were you like growing up? Have you had issues with keeping up with your peers, for example, in PE class? Did you ever have second wind phenomenons? Those are little clues that they can say, oh yeah, like, these are things I've always struggled with. So that tells you this is probably a chronic, long-standing thing since childhood.
That's fascinating. Okay, I have some new questions to add to my my list here. Well, then maybe we can chat about treatment, because I need your big brain to help me understand how to approach this. Can you walk us through your thought process when you're selecting your first line and second line treatments for myositis? I know these are like big, huge questions that are, each of these deserves its own book. But can you give us some kind of pearls on how you decide, how you make those treatment decisions?
Yeah, absolutely. So going back to the subtypes, this is why understanding the way we subtype myositis is very important. So I will start off with thinking, all right, what subtype do I think this is? Is this clearing dermatomyositis? Or is this, for example, a stand-induced myositis? Or is this MDA5? And I'll go down different algorithm as a result, depending on that. Within that, I will look to see, okay, what organs are involved. And it's kind of like our lupus patients, right? We think about what organs are involved. Everyone should be on hydroxychloroquine, but what's the next step? So I'll think about, all right, if you got this organ involvement, then we should think about this medication. And each medication that we use kind of has its own claim to fame. But the general thing I will say is, yes, most patients do need prednisone. Usually it's a milligram per kilogram, and then you taper them off over around 6 to 8 months or so, or earlier if possible. And then from that, if you're not quite sure upfront what this is, if they don't have frank ILD, I will often just turn to methotrexate or azathioprine if there's a whiff of ILD or if there's anything else I'm worried about. Those are good first-line agents. Mycophenolate we use very, very commonly, of course, as well, especially if they have ILD. Mm-hmm. Beyond that, you can use combinations of those as well. But beyond that, I really do rely on the subtypes to determine, okay, if this is HMG, CR, I need to start thinking about, can I get this patient on IVIG early, for example? Because we know those patients do really well on IVIG. Or if they have ILD and I'm worried about progression, then I need to start thinking about, do I need to start adding tacrolimus early? Do I need to have combination therapy with mycophenolate as well as tacrolimus? Or am I, okay, this is rapidly progressive, I should get cyclophosphamide or rituximab on board now. So again, another long-winded answer, but generally I would think about, start your prednisone early. If you need to get something on board, methotrexate's fine. Always try and start a DMARD on top, and then beyond that, rely on your subtype.
So Fergus, a question there, because this is really helpful. So in general, some of my teaching that I've heard is that if you're going to think about IVIG, it would be people obviously with cardiac, dysphagia, diaphragmatic, worsening ILD, I guess rapidly progressive, maybe MDA5, etc. Do you have any, am I missing something in there where you go, oh, if I see this and this, IVIG would be the way to go? Obviously, recalcitrant and failing everything, we kind of hit IVIG and also reassess to say, is this active disease or damage, and do I have the right diagnosis? But any other areas where IVIG might be a higher line therapy that you can think of?
Did you say the HMG-CR in that list as well?
Yeah, they would be because they're...
Yeah, so I think about that right away because there's reasonable data. These patients don't do well on steroids, right? They're on a stand for a good reason to begin with, so you kind of want them off it if possible. Your pregnant patients, IVIG makes sense as well. Bad skin disease is another one where you think about IVIG. And interestingly, IVIG, we've been using this for decades and decades and decades. It was only recently that they finally got FDA approval because finally there was a phase 3 trial that said, yes, this works. It's not, we're not imagining things. So I try and get it on board early for HMG patients. But if they're doing unwell at any stage, I would start adding IVIG. And traditionally it was thought maybe it wasn't fantastic for ILD, but certainly we're thinking it more in salvage early on, rapidly progressive ILD early on as well.
You mentioned kind of a group where you might use mycophenolate and TAC. What sort of group is that? Is that people with, severe ILD but not rapidly progressive, where you've tried MMF and then you add TAC? Or is there a subgroup where you're using kind of both of those at the same time?
It's usually the ILD patients that are progressive. Yeah, absolutely. We know TAC works relatively quickly, so we want to get that on board if before they decompensate.
And there are some people where it seems to help skin, but it's not our first line ever on skin.
No, yeah. I hate monitoring for TAC, so I try and avoid it if I can.
Well, we just tend to make up the trough anyway. It's like, 2 milligrams BID seems good without any sort of level. Because when you ask the transplant people, you often say, what level should I target? And they go, yep. And it's like, no, the answer was not yes or no.
Really?
Yeah. Our group says, yep, just do what you feel like. Because the level can have quite a range, and we're not trying to super immune suppress adding it on. We're just trying to get into maybe a range that might be okay.
Yeah, so I usually target 5 to 10 or high, or on the higher end of 10 at least
for your level.
Targeting.
Yeah.
And just to round out that, so Fergus, what dose do you start, and when do you do a trough? Just for listeners if they need to use it.
So I usually start around 1 milligram BID, or then I do 12-hour trough. So make sure you tell the patient get it first thing in the morning, because otherwise if it's messed up, then they have to go back.
Right. Okay. Perfect.
Can I ask a question about Ritux? So so again, this is impression, not reality, but even before the Rheum trial, which was kind of a strange design, so it's hard to show rituximab's better than rituximab, because that's really what the trial was in the end. Is A better than A? No, they were kind of equal. So with that in mind, I mean, a lot of us were trying rituximab before the trial, if we were in practice before then, and then also after. And I would say, I always thought, dermatos will do better, and maybe polymyositis, certain antibodies might not do as well. And I can say, because I don't use it first line, it's usually second or third line therapy. I can say I bat 50-50. And maybe it's me, and I can't tell you a phenotype that will do better, because I've tried it in all sorts of folks. And sometimes, again, they're treatment failures or only partial responders, or I can't get prednisone down. So I'm doing it for a reason. But I am sometimes quite happy and sometimes very underwhelmed. So am I approaching it wrong? Or Fergus, do you have, I guess, more evidence and eminence-based that will help the listeners?
Seems like most things are eminence-based in myositis, but so the Rheum trial, they looked at who did well in that, and it was patients who had certain autoantibodies. So I think you're right. If they had specific autoantibodies, it makes sense. Rituximab is depleting antibodies to begin with, or in my head it makes sense anyway. Who knows? So they found Jo-1, for example, and I think the other one was the Me Too patients did better on it. So those patients, I'll say, perhaps they have a higher chance of doing well on rituximab. I don't think that's a clear-cut, hard and fast, this is going to be your go-to medication every time, but at least it's another piece of the puzzle that I would be relying on.
Maybe kind of one last area of treatment I'm interested in, we have sort of touched on it a little bit, is your rapidly progressive ILD in MDA5. Are there advances in how we treat that? I've read some papers or heard about quote unquote triple therapy, not like the RA triple therapy, but MDA5 triple therapy. Can you give us some thoughts on that?
Absolutely. So the triple therapy was described a few years ago by a Japanese group, and they looked at, so their triple therapy is steroids up front, cyclophosphamide, and tacrolimus. And what they compared, they looked at patients who got it right up front versus step-up therapy, so one medication at a time. And they showed a lot of significant benefit. The issues with that study is they actually compared it to historical controls. So they weren't running two different arms. One would get step-up and another would get all three at the same time. And the historical controls potentially may have been sicker as well. So there's been some question just how useful that data is. The group that came up with that, I think they also didn't have access to certain medications based on the geography as well. So I don't think rituximab is readily available in parts of the world. So they didn't have access to that, for example. When that paper first did come out, did use triple therapy, and I still do. I think generally I still use triple therapy a lot. But some of our counterparts in the States, for example, they will rely on rituximab a lot more, just especially with the recital trial that came out recently that said, okay, well, perhaps rituximab is at least equivalent, if not worse, than cyclophosphamide. So more rituximab is being used. Mm-hmm. I'm starting to sometimes use rituximab earlier on, but it's just that when patients are so sick in the ICU, I find it hard to wait for that time for the rituximab to kick in. So I'll usually have a discussion with the transplant folks right away to say, all right, if they're headed down transplant, first of all, what do you want me to keep them on? Is cyclo safe, or do you think that immunosuppression risk is too high and you'd rather them be on rituximab? So for the MDA5 patients, get in contact with your transplant team and say, all right, if you guys don't care, then I'll probably use triple therapy for the time being. But if you have a strong preference, then rituximab is likely equivalent. It just acts slower. And for those patients, you're relying on the tacrolimus because that's part of your bundle in your triple therapy to take effect first.
Yeah, that's very interesting. I think about the few that I've seen in hospital that I worry about giving Ritux if they're about to go for like if essentially they're saying this person's going to need transplant, within the next month. And then, just trying to harmonize your therapies with what they're going to need for transplant rejection medications. So if you've given them 2 doses of rituximab, well, that's hanging out in their system for some time now. So I have wondered about that, but it sounds like it's part of a shared decision with, patient, family, and the rest of the care team there.
Yeah, and I feel the transplant team typically prefers Ritux from my experience.
Mm-hmm. Right. And I guess no matter what, they're going to be heavily immune suppressed around transplant, which high dose steroids, high risk of infection, PJP, all that stuff. So I guess they probably don't even think of our drugs as being as immune suppressant as we do because they're going to really blast them right during and after transplant. So a thorn in our side and the patients, and it is a pun intended, unfortunately, is calcinosis. So what do you think about JAK data, and do you think anything actually works in calcinosis?
It is so hard to treat calcinosis. So JAK data is reasonable for skin. It's not fantastic even for calcinosis. There was something published in a big paper. I forget which paper it was. It was a case series, but I think it was an N of 3 that said or am I allowed to say brand names? Tofacitinib. Yeah, something small. And it was said tofacitinib was useful, but you do have to take it with a grain of salt when the numbers are so small. Mm-hmm. Sodium thiosulfate, possibly. There's some data. I think it may be the pediatric groups that are looking at it now in trials that has some signal for improvement. And that data is still waiting to be published.
And I know that could be topical, but there's also now, I guess, some, I won't call them cowboys because I think it kind of makes sense, but they're trying to almost like electric shock therapy. They're trying to shoot it in under high pressure. And then, I can imagine the pain later that day for the patients because they'll get an inflammatory reaction and pain when you're breaking apart stones all over. But apparently shooting the thiosulfate right into a deeper area might anecdotally help some people. But calcinosis, the best thing would be to prevent it. But once it's there, I always say until we get the disease under control for a long, long time, calcinosis begets more calcinosis.
Yeah, absolutely.
Do we have any role for Plex in these various patients? I've seen some literature suggesting it's helpful for anti-SRP, but not HMG-CoA. I'm wondering about kind of the same theory of like, well, if these are antibody-mediated diseases, then Ritux should be really successful, and so too should Plex perhaps. But I'm not sure that that's totally borne out in the literature. What do you think of that?
We don't have fantastic literature on Plex for patients in myositis. The other subgroup I'll sometimes think about would be the MDA5 patients as well, where there's some data for Plex. Usually by then you're thinking of salvage therapy when you're kind of throwing the kitchen sink at them. And there's some data that perhaps patients with MDA5 Plex will do better as well.
Interesting. So maybe then kind of coming to what I think is our final topic is cancer screening.
Yeah.
So there was a really interesting international guideline I'm sure you're aware of on cancer screening that was Oldroyd in Nature Reviews in late 2023. And they gave us, as far as I'm aware, and definitely correct me if I'm wrong, kind of the first evidence-based guideline for cancer screening. But even there, a lot of the recommendations were based on low-quality evidence. Though, largely speaking, I think the recommendations sort of make reasonable sense. But I would love to hear your approach to cancer screening and if it kind of matches in some way what the guidelines suggested there.
Yeah, absolutely. So I actually was one of the reviewers on this paper here, so I kind of was able to kind of pick apart how they came up with this. And I think my practice has been fairly similar prior as well. So Aldrid's also from Manchester as well. So I think we kind of saw the data as it was coming out. So my practice kind of reflected that as it was coming out. I think it's a very, very good starting point. I was very excited. We've got screening guidelines for so many other conditions, but nothing in myositis. So this was the first time where at least I had something to hang on to that I could refer to. As you said, the data is not fantastic. So they went to myositis experts around the world and had them just basically go back and forth, say, do you agree with this statement? Do you not? And then this was generated as a result. But the risk factors that they've highlighted generally, for the most part, I think are what we know already. But it makes sense, right? So it's useful for a rheumatologist if they need a refresher on, okay, what are the antibodies that I need to pay attention? And it's very user-friendly. If you guys pull it up, there's a nice flow chart that goes, okay, these are your high-risk features, your intermediate risk factors, and your low-risk factors, and you just kind of check off. You count how many do I have. The issue with this, as you mentioned, it's not based on fantastic evidence at all. So when I was reviewing the papers, I said, well, how do we come up with age over 40 as a high risk? And I had a feeling it was based on one paper that was published, and that was based on a TIF1 paper where they said, okay, if you're age over 39, then that's considered high risk. But well, what about patients who are not TIF positive? You're still classifying them in that group, right? So what if you just had, any other antibody, your age over 40, that still counts as a check. So they kind of made that a very broad statement for the time being. That being said, though, I think this is the best that we have. This is the first iteration, and we're already trying to collect data to say, all right, for the next iteration, what can we improve on? And there are a lot of exciting things coming on. I was going to say, you asked about antibodies earlier, and I got very excited recently reading there are antibodies that now lower your risk of cancer. So those are being studied as well. So we got our TIF that are, increase your risk, but not all TIF patients get myositis. So if you have a TIF plus another one of these antibodies, your risk is going to be lower. So that flow chart is going to change in another 5 years or so.
So Fergus, on that, again, this was often eminence-based that some U.S. Specialists in myositis would say, oh, you need to keep screening. And it was, to me, it sounded cost ineffective and not choosing wisely, but annually for the next 5 years. And it's, well, if my patient is 42, that's a totally different risk than 79. So I never bought into it. And I think it was anecdotal, but they were saying, well, we still can pick up the cancer because maybe it's so small at the beginning. And this was before the days of routine PET scans in certain populations who are at high risk. So I kind of wonder if it was, they're finally picking up the adeno when it's detectable. But of course, if you think it's associated, was it chicken and egg, or presumably they're causing the myositis? So I think that having these guidelines will help us to maybe understand, and they will have another iteration. And sadly, we'll have about 10 more antibodies that the trainees will have to memorize for their exams in the next 4 or 5 years, because we're getting about 2 antibodies a year. I hate to tell people, but we might sort of know that, you have a high-risk one and a low-risk one, or you have weight loss and you can still swallow and you're older and you have certain kinds of rash and an antibody. Like when you start putting all that together, I think at least, as you say, it's a bit more rational than screen everyone with everything. But of course, we'll always say get your normal cancer screening up to date.
Absolutely. That's correct. Yeah.
Before we wrap up, Fergus, is there any other clinical pearls or items within myositis that you think we should know about? Maybe things I'm doing wrong when I send you
Dan, you could never do anything right. You could never do anything wrong. I read your consult notes. They're very, very, very good. Things to watch for. I'd say don't over-biopsy patients if you think it's a clear diagnosis. I think when I was going through training, I was always taught, biopsy them just so you have documentation. But if it's a clear-cut antisynthetase syndrome, for example, then you don't need to biopsy those patients. Another, actually, speaking of antisynthetase, if you pick up an antisynthetase autoantibody, if they don't have myositis, it's worthwhile following them for a while. Those patients actually do the worst if they don't have myositis but an antibody up front, because nobody follows them afterwards. So they can declare themselves later on. What else? Lots of new treatment options coming out. We've got lots of studies. There's a lot on JAK inhibitors, so watch for that. There's some studies now looking at JAK for muscles. Recently heard about CAR T-cell therapy as well. Very, very interesting in myositis. Still very early phase 1 and 2 studies. So that's another area that I think could potentially really revolutionize how we're doing things. But you could never do anything wrong, Dad.
That's what I was fishing for. Thanks.
Exactly.
It worked.
No worries.
Well, perfect. Well, Dr. Fergus To, thanks so much for coming on the podcast. You're such a treat to talk to, and that's really been really enlightening. So thanks for taking the time.
Thank you for having me.
Thank you so much. You're a heavyweight in this area.
That's it for this episode of Around the Rheum. For questions, comments, and future episode ideas, email us at info@rheum.ca or tag our Twitter account with your question at @CRASCRRheum. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fonwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening.